Good afternoon. Thank you, Judith. Can you hear me okay?
Yes.
Oh, wonderful. Well, I really appreciate this opportunity and have valued the partnership with the Illinois Association of Medicaid Health Plans. Judith and your team have just done a great job over the last several years of helping us fix some of our issues that are, related to Medicaid. And now we're going into the MMAI program, and we really appreciate it because it's great to address these things up front and get them fixed because we all want to be able to provide care and services as we need to. So thank you for allowing this to happen. And I also want to thank Jill Hayden, who also works with you as well as with ICAHN. She provides Medicaid policy support, and she's helped bridge the gap in many of these areas. So I'm going to present a general overview of today's program about rural health clinics, eligibility, the differences between the two different types, the different services, payment and billing concerns. Some of it may be to our critical access and rural health clinics that are on the call. It'll be redundant to you, and I apologize, but we wanted to have this program today to help our health plans understand more about rural health clinics. And I do encourage my fellow colleagues in our rural health clinics to put questions in the chat box or provide time a little bit later, because we really want to focus in on some things that may be confusing for all of us and create a better understanding. So these are some things I'm going to cover, and I tend to talk fast, so if I miss something, please feel free to ask questions and stop me. So thank you. All right. I wanted to start first with just a little bit of back about the rural health clinic program. It really began in 1977. There had been we have different waves, in our country. There's times we have shortages and then we have a surplus. Well, in the late 70s, we were beginning to have really, we'd lost a lot of physicians in our rural communities. They were moving more to our suburban and urban areas, and many communities were left unattended with physicians and support systems out there. So Congress created the Rural Health Clinic Service Act, and one of the things they did was to bring in nurse practitioners and physician's assistant nurse midwives to help cover because they didn't have enough physicians. And so that's really a critical point to remember, and it's really helped expand healthcare today. It's a program that's certified for Medicare and Medicaid. The clinics, they have to be like a physician practice or clinic and go through a list of conditions of participation, guidelines to make sure that they're in compliance and meet standards across the country. They have to be enrolled in the 855 Medicaid enrollment, just so that they can set up the billing process for rural health clinics. And, it started in 1977, and today there's over 450 rural health clinics. Now, rural health clinics really did not take off until 2000s, when critical access and rural hospitals realized that they need to start covering physician practice. Physicians were not wanting to own and operate their own clinics and practices. And so the hospitals then started to expand it and handle them so we can have healthcare today. So that's really why, back maybe 20 years ago, there might have only been 2,500, and now we have more, just because of the growing need and the change in our environment, which is okay. So the real definition, or why it came about, it's intended to increase primary care services in rural health communities. And what's different about rural health clinics and federally qualified health centers and other things, the clinic itself can be public, nonprofit, or for-profit entities. It doesn't matter, but most importantly, has to be located in a rural designated area. And those designated areas are either approved through state, they have to meet a state designated rural area or a federal designated rural area. And then the second part to it, the hospital has to be located, or the hospital, you can tell I live in the hospital world all the time. The rural health clinic has to be located in a health professional shortage area. And the health professional shortage areas are determined by each state primary care office. In their Center for Rural Health in Illinois, they have a section that determines health professional shortage areas. So it's something that has to be turned in statewide, approved federally, based on percent of providers per particular areas. So the rural health clinic has to be located in a rural area and an underserved, and primarily most of them are health professional shortage area. There are some what we call population group HIPSA, where they have a certain population in their community that's really underserved, that they can put a clinic in there, even though the other part of the county is well serviced, or in a medically underserved areas, which is a little bit another broader definition of underserved. And in some states, they're in what they call a governor designated area. Illinois at one time had a physician shortage area. Back in the late 90s, they had that. And over the course of the last 10 years, that's been discontinued. So in Illinois, primarily, if you're going to be a rural health clinic, you're going to have to be obviously in a rural area, determined, and then you have to be in either a HIPSA or a medically underserved area. There's very few population HIPSAs. And one other thing, as I mentioned in the previous slide, that was where we added the nurse practitioners, PAs, and midwives. You have to have at least a half of your staff, your practitioners, being a mid-level provider. So I'll move to the next slide. Okay, so now with rural health clinics, there are two types of clinics. Now, most of you on the call are probably most familiar with the first one. It's called provider-based rural health clinics. And they're owned and operated as essential part of a hospital, nursing home, or home health agency participating in the medical program. So, they're really owned by that entity, and probably 99.5% of them are owned by hospitals. The rural health clinics operate under a license. They have to be licensed, and governance and professional supervision of that organization. And they, that's what they're under this already designation, the hospital or home health agency or nursing home. So they really operate under their licensure and governance. So if you're applying to be a rural health clinic and you're provider based, you're going to fall under that hospital's board of directors, their CEO, and all that. And provider-based clinics are hospital-owned, like I said, 99.5% of them. And they're actually more than 70% of all the rural health clinics today, just because of that changeover that happened in the 2000s and 2010 when hospitals began to take over physicians and clinic practices. So there is a second type of rural health clinics, and we call them the independent rural health clinics, or rather term freestanding clinics, and they can be owned by the provider entity, and or else they can be owned by a larger system, and they don't seek to be a provider base. They have their own, their owner or board or something, their own local board can own and operate. They're not subject to the hospital governance and all those rules and responsibilities. And most of them are owned by a physician or a nurse practitioner or a PA or whatever. So just remember, there are two types of rural health clinics. One is the provider base, which is primarily owned and operated by a hospital. And the second is an independent rural health clinic that is primarily, which is owned and operated primarily by a physician, nurse practitioner, PA. Now, rural health clinic services is pretty obviously you're providing some type of medical care. And these services are similar to anything like with the physician fee schedule, how you get incident to. In other words, they have to be provided by physician services. And for the most part, like I said, they really have to, the physician has to be there to sign off that care was given. Now, rural health clinics, as I mentioned earlier, that they have nurse practitioners, PAs, and certified nurse midwives. They also can have clinical psychologists and clinical social workers, and their services and supplies are provided incident to. In other words, they have to have been ordered or approved or included in the care delivered by the mid-level. They can cover Medicare covered Part B covered drugs that are furnished during that. Sometimes you have to, if you're doing an excision of something, you're using an anesthesia, local anesthetic, or other kinds of things that are used in caring for the patient. So, that covers that. Interesting enough, rural health clinics do cover nurses that see patients homebound, either at home or through home health. And I think that's interesting, particularly in remote rural areas. They can provide certain care management services, so we get into chronic care management, and they can cover certain virtual communication. So I don't think it's any different than what you would expect it to, but remember that really apply to, incident to and things in the outpatient area. Um, and as far as the operations, they have to employ a nurse practitioner or PA. They can also contract with a PA, NP, clinical psychologist, and certified nurse midwife, and a clinical social worker. I mean, they can contract with them. There for a while, several years ago, you weren't able to even contract, and now you can employ. Obviously, you want to employ. You have to employ at least one, but you can contract for others to cover. And remember that you have to have either a mid-level nurse practitioner, PA, and you could have a nurse midwife open 50% of the hours. They have to be there 50% of the hours open in operation. And CMS is very strict about that. Sometimes the PA or NP is off on maternity leave, or they've been having surgery, and a physician or somebody else fills in, a physician or fills in, then you just have to make a note about that. But they're really strict about that as CMS. They can provide certain diagnostic lab tests, generally CLIA, such as pregnancies tests, a CBC and urinalysis and so forth. And they can can do a draws for labs and other things like that. They don't have x-ray equipment. And they don't do pulmonary tests or stress tests there, because they're really not part of their physician type services. They have drugs and biologicals to treat emergencies. A lot of them give vaccines and so forth. And they have to contract with one or more hospitals to provide necessary services. In other words, they have to have a liaison with a broader and more advanced healthcare system. They have to have their own quality improvement. They have to post their operational days and hours so people know. And you can't provide any clinical care. In other words, a nurse can't come in at 8 o'clock and do blood pressures without a nurse practitioner or physician be on staff. So there's some strict rules there. And they can't be just primary mental health or rehab. They have to be able to provide medical care. The state guidelines, and some of them even have some dental services. So just to give you an overview, if you're not familiar with operations, rural health clinic patients, it's interesting, I saw this the other day in some research, and the median number of rural health clinics by a medical provider was 3 per year, with a mean of 4.8. I thought that's interesting. So the median distance for Medicare traveled is 6.2 miles. And that's one of the reasons for rural health clinics. So people that particular Medicare and Medicaid, that was one of the reasons why they set up rural health clinics, to address those two populations. They don't have to travel very far. And we know distance is a problem, and elderly have a hard time traveling. And so that's really the reason why, it being a government program, even though you can take insurances and self-pay and so forth, it still is primary there. 22% of the Medicare patients are under the age of 65, 38 in 65 to 74, 75 to 84, and over 85. And we're getting more and more octogenarians. 58% of the Medicare patients are female, and 91% are white, and 6% Afro-American. And so I think you're going to see that the Afro-American other population growing as our healthcare and our rural communities begin to change. The rural health clinic must, so if you come into the rural health clinic and you're going to bill Medicare or Medicaid for it, you have to show it's I put medical, should be medical's necessity. I missed a C in there. Face-to-face medical or mental health visits, or qualified preventive visits by a beneficiary rural health clinic. So in other words, it's got to meet medical necessity, and it has to be face-to-face. Now with telehealth, there's some flexibility there, but it's for actual care, and you can do some prevention. And a qualified rural health clinic must meet the skills of the practitioner. So in other words, you can't have care that if you can't bill for services that a physician provides that a nurse practitioner can't. You can't bill for nurse practitioner services if they're doing physician services. That has to meet the scope of the practitioner. And it must take place at the rural health clinic, other than the home nursing visit. Beneficiary home or assisted living, like I said, it can cover those things. Staff, I know in Princeton, where I live, the rural health clinics, they will go out to the nursing homes and do a visit in the nursing home, skilled nursing units, or assisted living. So you can go out and bill that, but it's through the rural health clinic, has to meet medical necessity. And you could even charge for going out the scene of accident, but I don't see that happening very often. That's more in remote area where there's not, large EMS systems and so forth, but that just has to, remember, rural health clinics has to cover our whole country globally. So The rural health clinic cannot take place at inpatient or outpatient hospitals. Now, some hospitals have swing beds or distinct SNF units and so forth. That's a different story. They can go in there, but not as far as actually inpatient or outpatient care. That doesn't matter whether you're critical access or long-term care, a LTAC facility or whatever. A facility has to have special requirements, that exclude the rural health clinic, and cannot more than one visit by the practitioner the same day. Now, because it counts as a single visit, because they get paid, these rural health clinics get paid one encounter fee. And so you can't bill for 4 or 5 multiple things that you can do for fee for service. Now, there are times when somebody comes in and they see the doctor for blood pressure control, and lo and behold, they go home and they're in a farm accident or something like that. And that can happen, and they can come in and get stitches and so forth. And that becomes a different diagnosis. And a qualified mental health visit on the same day can't do those. You have to schedule them different. And then the annual well visits or mental health visits on the same day. If you're going to do those annual visits, you can do them that day. And if somebody has an issue, a medical condition, you have to schedule them another day. It's not an all-inclusive bill, or else they can bill for both of them. But you can do it, but you're only going to get paid for one encounter. So that's the big deal, is how it's being paid, and why you cannot do it at the same time. You can't be it's one inclusive encounter rate. You can't do multiples of it. Okay, and we can cover those questions as we move forward if you have that. And remember, freestanding, there's 2 different kinds of freestanding and provider-based. The freestanding is subject to maximum payment per visit. Okay, so in other words, Medicaid and Medicare for freestanding, they set a rate every year, and you pay whatever that rate. Doesn't matter which clinic you're in, whether you're in the north or south of Illinois, that rate is consistent. Now, if you're in the provider-based clinic, the Medicare sets that rate based on your cost report done the year prior, and it's updated as it moves along, because you can have different costing of staff salaries and supplies and things like that. Or if you're doing lab tests and other things like that, that's all wrapped around in that one provider-based rate. Generally, freestanding rates around $85. However, last year during the CARES Act, Congress passed where the freestanding clinics, that rate will be increased until it reaches $100 or $150 per visit by the end of 2028. And so there's an increment of increasing $100 for so many years. Not $100, about $10, $20 every year for up to 2028. And that's different because it's all max. It's not adjustable. Where the provider-based clinic, it's adjustable. Some provider-based clinics, it's $120 a visit. Some of are $500 a visit. It depends on the cost of providing care for that. And some of that has to do with administrative overhead and salaries and so forth. And that's why it's been important to rural hospitals and critical access, because of being able to bring physicians and covering their salaries and keeping them locally. We've been able to do it for the rural health clinic, and that's very important. With the CARES Act that I just discussed from last December, they put a cap on that, and we're no longer able to set up and adjust the provider rate. Now, whatever the provider rate is for rural health clinics, provider-based rural health clinics today, before that bill passed, that's set. It's not going to go away and become a freestanding rate, but it's going to eventually be phased out unless Congress changed it again. But remember, the rate is all inclusive, and just like the freestanding, all inclusive for 80, 90, whatever dollars, the provider rate is all inclusive for, whether it's $125 or $500. And remember, Part B, coinsurance are waived for preventive services and so forth. Talking about well visits and deductible. So rural health clinics, they can provide general care managed chronic care management program and behavioral health called behavioral health integration, psychiatric collaborative care model. And I don't have too many of our hospitals doing that because of the services that I'm aware of, but a number have behavioral health and chronic care management. And in doing that, the bill codes, and please do not take me verbatim on these billing codes, but I know care management codes use HCPCS G0511, G0512, and it's that G modifier that has to be in there. And I do not intend to be a biller, pretend to be a biller, but I just wanted to share that there is a different billing number. So medical plans, if you're looking at it for care management, they will have that modifier. Okay, rural health clinics, obviously, they can give your biologicals, flu and pneumonia vaccine, and they don't, those costs for doing it, they're reimbursed for that through their cost report. And the beneficiaries don't pay any co-insurance or deductible on doing that. Hepatitis B, the same thing. The rural health clinics, the cost of a hepatitis B vaccine, its administration, it gets the same. Other qualifying services on the same day. The rural health clinic can bill for this vaccine and its administration separately, and there's no co-insurance, no specific rural health clinic billed. Now, like I said, I'm not pretending to be a billing expert there. I just want to highlight these specific differences and unique things that go with the rural health clinic program. Now, virtual communication, this all came to life actually even before the pandemic. January 1st, 2019, Medicare pays for help for virtual communication services where the practitioner provides the beneficiary at least 5 minutes of billable RH communication technology evaluation. And the benefit may have a billable visit within the previous year. The service must meet the following: no need for services within 24 hours, and did not get a related service within 7 days. So it's really follow-up virtual visits or a phone call and things like that. But it has to be at least 5 minutes long. And once again, there's a HIPIC code, and you're using a G modifier. And I don't know if Jackie King's on the webinar today, but she's our ICAHN coding expert, and she can certainly update us on those things. But once again, I'm calling your attention to these unique aspects of rural health clinics. Telehealth services, traditionally rural health clinics could only bill as an originating site. Under the CARES Act, the rural health can also bill being a distant site and bill similarly as other telehealth service on the physician fee schedule. So they have, that's really a change, and we hope to make that permanent. It's in effect for a couple more years. Illinois, Medicaid does cover that, and Medicare does cover telehealth services. We're hoping that it does get made, all these payments, and being able to bill as a distant site. We hope that will be passed and taken care of over the next few months before the public health emergency officially ends. So that's there, and it has its own coding and process there too. Okay, the one thing that I wanted to emphasize: cost reports and annual reconciliation. Rural health clinic must file an annual cost report that determines their payment and reconcile interim, and it covers things such as bad debt vaccines, and if you're actually, participating in graduate medical education. And so the hospitals that are provider-based, get that particular additional payment because of their cost report or bad debt and other things that go with that. Now, when all rural health clinics have to file a cost report. Doesn't matter whether you're freestanding or provider-based, but the independents file a different one, and the hospital-based complete a worksheet for that. So not that you have to know those details, but realize there's two different processes going on, and that's why there's different rates. And the cost reports are submitted to their MACs, and then they figure out total allowable costs, total visits. They also, MACs also monitor to ensure that the rural health clinics are receiving and are doing enough visits. Now there's like for physicians, you're supposed to see 4,500 visits a year if you're doing full time. If you're a nurse practitioner, I think it's down to 3,000. So anyway, there's some productivity measures in that I did not cover, and the MACs do check for that when they do a cost report. It's not important today's conversation, but just to know that there are some requirements, and in these rural health clinics, they have to meet, they're surveyed once every 3 years, by local Department of Public Health, not so much local state Department of Public Health. Some of our rural health clinics are surveyed by Joint Commission or the compliance team or the 4 quads, but they have to go through a survey process. They have to meet standards, and those things are monitored all the time. And then when they fill their cost report, they have to put in their productivity, the number of hours of their practitioners and so forth. So this is a well-managed program. As far as billing issues, as I said, in Illinois, there's one set rate for Medicaid billing. With Medicare rural health billing, it's provider rates. There's no set rate. one established rate per clinic. And that's where I think sometimes it's become confusing, particularly if you're a new health plan and you're trying to understand what the heck is going on with these rural health clinics. We over the course of time, when we added Medicare managed care organizations to Illinois, because Illinois Medicaid HFS had a set rate for rural health clinics, it was probably easier to manage. And now that you've added Medicare, the dual eligible Medicare MMI managed care, then you have now these provider rates, and they're different rates, and it can be very confusing, billing numbers and so forth. And so I want to stop there and really open it up and see what kind of questions that you might have. I tried to cover some of the basic elements of a rural health clinic, that there's two different types. They've got certain responsibilities for staffing. There's certain things that they have to do for payment. They have to show medical necessity, what things are covered as far as their services. But like I said, as Judith mentioned, that this spring, summer, the program, the MMI program in Illinois, has been expanded downstate to our rural communities. And, most of them have Medicare patients coming through, and through our rural health clinics, and that's a new program for so many of you. So our hospitals have had a number of situations where they're having billing denials. And because, I think we're not all on the same page for understanding the programs, it's sometimes difficulty to get resolutions. And so I put this out here, tried to cover these things. Says that I don't plan to be a billing expert, but I do know about rural health clinics. I've set up a number of them over the years. I've worked with the hospitals in doing that. It is a little different process with the payment thing. And what's covered in a counter rate and the billing. And interesting enough, rural health clinics up until about 3 years ago did not have to put CPT codes in, because it was just one encounter rate. Now they have to do that, and they have to be very specific now about their modifiers, and that's where the G codes and so forth come in. And that can certainly be a webinar in the future, again, Judith, if they want us to cover some of those particular billing nuances. But today is really laying the groundwork for discussion. So, Judith, should I stop now and see if people have questions, or open it up to see if the hospitals want to share some of their situations? What would work best?
Yeah, let me just thank you so much for that presentation, first of all. It was extremely informative, and I think a follow-up webinar would be great. I just wanted to cover some of the questions that we got in the chat really quickly, and then after that.
Okay, I didn't see them. Is there a way I can open them up and see them, or just you see them?
It's in the questions. I can read them. So
okay, all right. Oh, there.
The first one is, does the rural health clinic have to apply for an additional category of service of 027 to bill for a clinical social worker?
No, I think they. I'm not an expert there, but they have to. It's all in the code. I don't think they have to apply for that. It's just all in. They have to make sure that they have a social work. It's clinical licensed social worker. They have, obviously it has to be approved licensed provider, and then they have to set up, that bill by minutes or services provided, and then it's a billing code. So we can send out the billing code information to them. Would that be helpful, Judith?
Yeah, that would be great. And then also with that, we have a lot of requests for the slides. So would that be something that we'd be able to send to the participants?
Sure.
Yeah. Okay, perfect.
So I need to get your behavioral health codes. So we'll get that for your group, and we can send that out. Okay.
Sure, perfect. So those are the only two questions that I had in the actual chat, but if you have any more, feel free to shout them out right now.
I know hospitals have had difficulty with denials, so it's your time to share your information.
Yeah, and if there's no questions, or if you guys just prefer to put them in the chat box or the questions tab, no worries. You can feel free to keep doing that. But if you want to open it up to some of the hospitals or some of the partners that you have on, that would be great.
Yeah, that'd be great if you all would share your information. I know we've had several situations where it's been hospitals have denied, and they don't know who to contact in the health plan to handle it. Is there a separate division for MMI, claims and so forth?
Yeah.
Okay. I hope I don't catch anybody off guard. Julie Reeder, are you on from Graham? I know you particularly had some issues. Anybody? Okay.
Well, can I ask?
Maybe people are shy to share their
I
issues.
know.
So
Yeah. We can go back to the questions really quickly. Is that okay? Because I just got an influx of them. Is that okay?
oh, okay, great.
Okay.
Thank you.
I have one, Pat, that says, what are the recommendations for overlapping services when you have a separate clinic and hospital systems, i.e. labs at the hospital and face-to-face with at the clinic?
That really is what the plans, what are they going to cover? But rural health clinic, they don't bill for hospitals. So are they saying that they've had labs drawn at the hospital?
So
I can't see the questions.
yeah, he just this is from Alexander Kemmer, and he was just specifically asking about recommendations for overlapping services.
Overlapping service. There probably shouldn't be overlapping services because rural health clinics provide their own unique services. They don't provide services in the hospital. So if she could send me an example, I'll be happy to follow through and get an answer for her.
Okay, perfect. Would you mind, do you have the access to the chat box, Pat? If not, I can put your email in.
Yeah, it's crazy. I've been clicking and clicking and it won't open up for me.
No worries. I'll put Pat's email in the chat. So if some of the questions that you have follow-ups to, you can go ahead and reach out to her. But let me get to some of these other questions. The next one is, can we get some information regarding the actual MMAI plans? And yes, you can. I don't know, Pat, we probably have information on that, but I'm
I
sure.
don't know about the different plans. It might, see, this is where we need to, begin our discussion. So maybe the next thing would be to identify the different plans, how they do their billing and practicing and following up. Is that a way to build a profile?
Yeah, and it's also information that we can send out, links with information once we in the post email to this webinar. So
Yeah, I think that's what they're looking at. What do the plans, what's their approach and how do they cover it and who do they contact and so forth?
okay. This is also a great question. It says, can you describe where you get each RHC's specific encounter rate?
Yes. The hospital, when they have to first, they're registered with the MAC. And I think I'm going to say it's the one out of Florida. And that MAC, they get their cost report, and then the hospital should have a rate. They should receive a letter saying what their provider rate is, and then they should share that with the MAI plan so they know what that rate is when they're a provider-based clinic. So the hospital should have that rate. They should have a letter from the fiscal intermediary or the MA, Medicare auditor contractor, that they should have their rate in set, their most recent rate, and they need to give that to the MA plan. And when it changes, then it really should be the hospital's responsibility or clinic's responsibility to notify the plans that their rate has changed. And I don't know if the hospitals know to whom that information should go.
Okay. I'm sorry, Jamie, and Jennifer, I see your hands are raised. So Jamie, I'm gonna unmute you right now. Go ahead, Jamie. Jamie, can you hear me?
I can't hear her. Yeah.
Okay.
Can she type in if she can't?
Yeah, if you guys can type in, if you're not able to, or if I'm not able to unmute you, please type in the questions tab.
Are you getting questions from them then?
Yeah, we can go back.
Okay.
Okay, so it says with the managed care plans, can we bill for the flu vaccine?
Well, you should be able to, because Medicare does under the under the rural health clinics. You get your cost for, I think you can bill for the administration of it, but the vaccine itself, it's covered through their cost report. So it's set in their interim rate, but we'll double check on that with the MMI.
Okay. And then we have another question in regards to issues with MMAI plans note paying RHC rates. Is there just some general kind of feedback that we can give?
Okay, I think what it boils down to, if your hospital for your clinic or your clinic has received a letter from your fiscal committee or your MAC that sets your interim rate, there's got to be a process to get that interim rate to your Medicare, to the MMI plans. And then they in turn should then set the rate up for the rural health clinic encounter or services provided based on that rate. And in a provider rate, remember, is different than the freestanding. The freestanding has a set rate, for Illinois, and a set rate for Medicaid, and a set rate federally for rural health for Medicare patients. Medicaid, Illinois is a set rate, and Medicare is a set rate for freestanding. If they're provider-based, a hospital-owned, generally out of hospital-owned, the provider rate for Medicare patient differs from place to place, and that's where they get that interim rate from the rural health, from their MAC. As far as Medicaid, for a provider-based clinic, it's the same as freestanding. But for Medicare, and that's what the confusion has been, is that when you get into the MMI, they have the hospitals, these provider-based clinic, have a rate set, and it's based on their MAC, on their cost report, and they should have a letter that verifies what that rate should be. And that rate will change from time to time. It can go up and down based on the cost of that clinic. So it's very important that the rural health C that's provider-based communicates with the MMI so that they have that rate, so that can be adjusted.
Okay. Okay. So are there some common denials you're seeing from all of the MMAI plans when it comes to encounter rates, billing codes, et cetera?
I can't answer that. It really has to do with, I can't answer that in specifics. What I've heard from the hospitals that have these rural health, provider-based rural health clinics, the concerns they have is that they're not getting their full rate. They're getting probably the state rate or something like that. They're just getting a set rate, because I think understanding that under Medicare with the MMI plan, that provider-based clinics have a different encounter rate.
Okay.
And it varies from clinic to clinic. And so I think that's a process that we have to work to clean up.
Okay.
But I don't know who, I think what the reason we're having this conversation today is so that we can find out, Judith, you and I can find out how we can get, resolution to this. Is there a process for doing that? I talked about having to have that letter. I guess we need, some additional conversations so that, we can have a clear message going forward. This is what it's going to be. But that's how it normally works.
Absolutely. So I've been getting a lot of requests for just us to unmute the attendees. So I have opened the mics. You would then have to unmute yourself if you want to speak. So if there's anyone that wants to say your question aloud, if you can try to do so now. You just have to unmute yourself.
Technology is wonderful. Sometimes
I
it's
know.
smarter than we are.
Okay.
I think they must still be having trouble, Judith.
Yeah, I think so. Well, I'll just go to another question. This one is a situation that someone is explaining. So she says, I've seen an instance from another facility that received a remit for an MMAI account with a co-insurance applied. Our understanding is that we bill one payer and receive one remit without any secondary billing. No MMI patients should receive a bill. So what would we do with the outstanding coinsurance in this case? This is a hospital billing, not a RHC.
Well, I couldn't answer that. We'll have to get some information. Like I said, I'm not a billing expert, and it may take us to, work something out with the plans and resolving that. And that was typed in. Will you get a printout of those questions?
Sure.
Okay. I think we'll have to do some follow-up. If we have to, we can certainly contact CMS and get clarification too. So if we can't find clarification within our own information with MMI plans, we can contact our regional office or the rural health clinic expert within CMS, because this is new for a lot of people. So.
Right. Okay, Megan, I see that you said you tried to unmute yourself. I've unmuted you. Can you speak now?
Yeah. Hi, Pat. This is Megan Weaver from Mason District.
Oh, wonderful. Thank you for jumping in.
So I guess my question in regards to the MMAIs not paying the encounter rate. So we have one specific MMAI plan that I don't know where to take it in regards to paying our encounter rate. So I might bill $100, but that's all they're paying me. And we've tried to talk to our rep and let her know that this is not how that process works. And we get nowhere. So where can I take this from here?
Okay. Megan, this is the reason why we're doing the call today. What Judith and I are going to do is we're going to reach out to the plans and see now that they have some general info, some additional info. Some of them weren't familiar with rural health clinics. And we can also work with HFS too. We have an avenue through that to explain that there's confusion about provider-based rural health clinics under Medicare, MMI. So if you and I can talk offline, Megan, if you can maybe share a couple examples or maybe some that we can include that information when we do the follow-up. So I'm glad you're saying this so people understand that that's, for the most part, the biggest issue, because now we've got Medicare and plans aren't used to the Medicare and don't understand our uniqueness with the cost report.
Right. Right. Yeah. Now that's been a battle. One specific, one plan specific. It's been a nightmare.
Okay. Well, I'm glad you shared that. Judith, does that make sense to you what I'm proposing?
Absolutely. I think it's great. And
Okay.
I did unmute Kristen.
Okay.
I know she wanted to answer the question. Go ahead.
Actually, it was more of a statement. I work for Aetna Better Health, MMAI, and we provide 2 EOBs in regard to that question about a single EOB. So the primary Medicare EOB will come out and you'll get a payment. It looks like there's a share of cost or a deductible or however it's worded on the EOB. Then the secondary will pay, or sometimes not, depending on what the service is. So if the Medicaid rate is higher than a Medicare rate for something, we'll pay the difference between the two. If Medicare pays more than Medicaid, which is usually the case, we only pay Medicare and then you write off the Medicaid portion.
That's probably confusing for the hospitals, because when they bill Medicare now, they get their Medicare rate. They don't deal with Medicaid being more or less. It's not entered in.
Well, I'm talking about like we'll say other procedures, it's not just an encounter. So an encounter is one thing, but say you do an encounter and then somebody, I don't know, gets stitches or has another procedure or labs or something like that. That would be where the other payment portion is coming in. Does that make sense?
Okay, so it's
so
not.
you are going to get 2 EOBs, and without looking at something specifically, it's hard to say, but I have seen, I personally, and I do work with RHCs and FQHCs. I don't know. I haven't really seen any claim issues come in from any RHCs recently, but I know with a lot of the FQHCs, a lot of providers actually end up billing Medicaid encounter codes. So we're going to pay the Medicaid encounter rate. But if you bill a Medicare encounter code, we will pay that rate. So that would be also maybe an issue to look at as to what code you're using.
Yeah, that's probably some of the issues there. And I don't have specifics, but Megan and several others have them, and we can share them because apparently the information's not getting to you or to others, other plans. And so we have to figure this out. So I'm not a billing expert, but I can get you the details, and maybe you can look at it and you're just going to go right away, oh, well, that's the issue.
Yeah, we've sent plenty of rate letters.
Megan, they're asking if you can state the payer. I know earlier you mentioned that it was one in particular, if you're still able to unmute yourself.
Sure, it's Molina.
Okay, perfect.
I do know that, I've heard comments from about most all the MMI plans, and it's probably part of that implementation, new billing and things like that. But we've had a couple where they've gone for several months and haven't been able to get resolution.
Do you want me to say it and tell me?
Mm-hmm.
And Pat, hey, we've been dealing with this for quite a long time. I mean, more than just months, because
Okay, I didn't want to
we've
speak
been
to
in
anybody too much. Yeah.
we have had that MMAI plan with Molina for a long time.
Have you? Okay.
And as I open mics to attendees, if you're not speaking, can you just please ensure that you keep it muted though? Lauren Polite also sent a very informative link where you can find more information about the MMI plans contacts. So I'm sending that right now to the entire chat, and we'll also include that in the follow-up email. So please look out for that.
That's great. Thank you.
Hello, this is Chris at Warner Hospital.
Yeah.
And we just wanted to, we've kind of put the chat out there, but we hadn't gotten a response. But I wanted to reach out, and we're particularly having trouble with Aetna Medicare, not the MMAI, but straight Aetna Medicare Advantage. And they consistently, they're not paying our rates, our RHC rates. We send them our letters and they do not update it. And it's a consistent, the same amount across the board every time they pay the same amount. So we don't know where that rate's coming from. It is not our RHC rate. And we're not able to get any contact there. We just have to talk to provider services, and they just say, nope, we paid your rate. And they're no help. I mean, we cannot get this resolved. We have lots of claims and issues to the Aetna Medicare Advantage.
I know somebody was gracious from the Aetna plans. Are you able to address that?
I don't work for the commercial plan. I don't work for Medicare Advantage, so I don't have any contacts there. It's a completely separate business line. I'm sorry, I don't have any. I can't help.
That is what we're told too, but we cannot get anybody to help us on that part of that line of business.
Are you owned by a hospital?
Yeah, we're provider based, yes.
Okay, well, my understanding is, and I don't have a lot of understanding about how the Medicare Advantage works, but that Medicare Advantage only assigns provider reps to larger groups, like hospital-owned groups or like very large independent groups, but like small, single provider groups with 3 or 4 providers in them do not get assigned reps. So I would reach out to somebody in your hospital billing department, in your hospital credentialing or something like that, and find out who they have as a provider rep for the hospital system.
Yeah.
And that would be the person you would talk to.
Yeah, we are a critical access hospital, and I am that person, and there is nobody. We have nobody. We're a small hospital.
Hey, Chris.
Access. Yep.
Hey, this is Megan at Mason District.
Yes, hi.
We have that same problem, so maybe we can get together and we can hammer them.
Yeah, I think there's several. I mean, I think everybody as a rural health center that's tied to a critical access small hospital is having the same issues with Aetna Medicare Advantage, yes, for their rural health centers.
And that's something that we can address on a separate, if that's a topic that, a lot of people are dealing with at this time. But this particular webinar is for MMAI. So we just want to we only have 5 more minutes, so we just want to keep to that topic. But feel free, please, to reach out to me via email with any questions or concerns. Lauren, I don't know if you're able to unmute yourself, but Lauren Polite, she just wanted me to reiterate that Medicare is always the primary insurance. Medicaid is secondary when it comes to MMAI. So for things like the flu and COVID shots, those are billed to Medicare.
Thank you. That was great. And Chris and Megan,
Well, actually,
we can follow up with
you're not going to
later.
bill it to Medicare. Sorry, this is Kristen from Aetna MMAI. You're going to bill it to the MMAI plan. You're not going to bill it to Medicare and then bill it to Blue Cross or Meridian or anything like that.
Okay. Lauren, are you able to unmute? I see you're chatting. Give me 1 second to try to unmute her. Lauren, are you able to speak now?
Oh, yes. Hi, everyone. Yes, sorry about that. I apologize. Kristen, I meant, you had mentioned making sure, that you use proper Medicare codes versus Medicaid codes. So yes, if someone's on that MMAI, obviously they're going to bill to the same insurance company, but it's important to know that Medicare is, sort of always primary. So I'm sorry about that confusion. I'm happy to take Aetna, the folks having trouble with Aetna commercial. I'll do my best to get you connected to the right folks. You can send me, so it's just lauren.polite@illinois.gov, and I'll connect with, because I'm the account manager for Aetna, Health Choice Illinois, and MMAI. So I have, I'll see what I can do. I just want to send folks to our HFS website. There is a lot of information. I have found some, like an introduction to the Medicare Medicaid Alignment Initiative. It looks like it's a little bit outdated, but there are some like network, it looks like some network escalation contacts, and I don't know if they're still current, but on the Medicaid side, we do have escalation. We do have some escalation contacts, and there are account managers for all of the plans. So we have HFS people who can help facilitate resolution. We also have a provider complaint portal that's on our HFS website, but we do ask that any sort of grievance or complaint or go through the original MCO's process first before it gets put into the provider complaint portal. So just to try to help troubleshoot, but I think another call, and we can have on some of our MMAI billing people as well as the MCO folks, and I think that could be helpful. But thanks everyone for your participation today. Thanks, Pat. I learned a lot.
Thank you, Lauren. Yes, we know that this webinar taught us many things, and one thing is that it warrants a follow-up. So we will definitely be planning for that. We just want to thank Pat and ICAHN so much for partnering with us today, and we know that this is just the beginning and there's a lot more information that we all need moving forward. Like I said, we will be sending out a follow-up email to this webinar that includes the slides and some resources and links to information, but feel free please to respond to that email directly to me. Pat will be CC'd on there, and any questions that you guys have, we will try to get you the information as soon as we can. So just feel free to reach out, and if there's a topic specifically that stemmed from this webinar, please feel free to include that suggestion in your response to the email. Okay, so just take a look out for that. It'll be some good information. But again, thank you so much for your time this afternoon. Unfortunately, we are at time. So thank you for joining us, and we will keep you posted on following webinars with pertinent information in regards to this. Okay, so please enjoy the rest of your day and thank you so much.
Thank you, Judith. Have a great day, everybody.